Welcome to the Soft Network podcast. This is going to be our first interview for our episode for 2026, and I can't wait for everything we've got on store. Just a quick heads up, we may have one more episode before we jump into a mini series focused on psychedelics. As I've said before, we're committed as an organization to bring you high-level SMEs in a lot of different areas and discuss a lot of important topics. And this happens to be one of the most important topics, or one of the most, hate to use the word trending, but one of the hottest topics within our field, and specifically within the special operations community. And so we're going to bring you several interviews of providers. We've got a doctor that's going to come on. We've got coaches. We've got individuals that are trained and work in this space fairly regularly. And so it's going to be hopefully very, very informative, very, very rich. And at the end of the day, we don't want to just hit on one single angle. When it comes to psychedelics, we want to hit on all the different perspectives and areas where people have questions, people have concerns, people have had tremendous success, people have had failures in this space. We want to highlight all that and really dig around and have a healthy conversation. So keep an eye on the website, our YouTube channel, and of course our LinkedIn page to get those announcements. But on to today. So we've got an amazing guest today. The conversation was awesome. Without further ado, Ryan Soave. Ryan is a licensed mental health counselor, a coach, an educator with more than 15 years of clinical experience working at the intersection of trauma, addiction, and performance. His approach blends evidence-based psychotherapy, somatic awareness, and contemplative practices to help people transform stress responses and expand capacity for resilience and growth. Ryan is trained in EMDR, Somatic Experiencing, post-induction therapy, breath work, and Yoga Nidra, integrating clinical depth with embodied regulation practices that support the nervous system's mastery, emotional clarity, and peak functional capacity. Known for making complex neuroscience accessible and clinically actionable, Ryan uses metaphor, story, and compassionate inquiry to help clinicians and clients deepen understanding of how the body and mind co-create experience. His work invites a shift from avoidance of discomfort to skillful engagement with challenge, whether in trauma recovery, addiction work, or performance contexts. Ryan has been featured on the Huberman Lab and DeadTalks podcast, and his forthcoming book, How to Feel Bad, Embracing Pain as the Pathway to Peace, reframes discomfort as the doorway to resilience and meaningful change. Me and Ryan had a great conversation. Obviously, he comes from the realm of addictions, and we talked a good bit about that, but specifically what's behind addiction. And then we get into some of the evidence-based practices that he's used and uses within his practice. We discuss the residential treatment approach and a bunch of other things. So without further ado, episode 11, Ryan Soave. We'll just get rolling. Ryan, really appreciate you coming in. I know your time's valuable. I'd love to hear a little bit about your background and just how you got into clinical mental health, if that was a conscious choice or just, roads merging at some point in your life.
How I got into clinical mental health was after I got out of my own mental health challenges that had me in a pretty significant bind. It was not what I thought I was going to do when I grew up. It was not what I planned when I was in college. I was a business major. And I'd always had this idea, though, that I wanted to, be in service in some way. I wanted to help people. I thought I wanted to be like a teacher or something like that. But then at some point I saw what teachers made. My mom was a teacher. I saw what she made. I didn't really realize it because my dad had a business. So, but once I figured that out, I was kind of like, well, I don't know how I'm going to be able to live the life I want to live and also be a teacher. I'm not saying you can't, but that was the way I thought. So I kind of had this orientation that, I'm gonna go out in the world and make money, and then once I make enough, then I'll go do what I really wanted to do. Um, and so I did that. I went and went to I went to college, and I got out, and I was in a family business for a bit, and then I started my own and did pretty well at a young age. And then some things started happening in my life and from my history and how I was relating to relationships not working out, or you know business not going the way I wanted, and my drinking really took off. It was much deeper relationship with alcohol than that, but it got to a place where I was having a hard time functioning. And fortunately, with family and some friends, I got some help, and very fortunately, I found good treatment and went away for a significant period of time. Not everybody has to do that, but it was what I really needed. And through that, there's a spiritual intervention or divine intervention where I lost most everything financially, which seemed terrifying at the time, but it's probably the best thing that could have happened. And I got back into this idea that I wanted to help people. And at this point, like, I'd seen what therapy and psychology and psychiatry could do, and I'd experienced this, like, a lot of people go away to treatment and they just can't wait to get out. Like, I loved it. It felt very safe to me. It was, I didn't have my phone. My life had gotten to a place where, I was 32. I'd done a lot of adult things, but I didn't feel like an adult in many ways. And somebody asked me what I wanted when I went into treatment. I remember this therapist, and I just said, I just want to be able to answer the phone, and this is before iPhones and the visual voicemail. And so I would hide from my phone, but I wouldn't shut it off because I needed to see who called me. And I was just like, what I thought I wanted out of life was this, like, really simple thing. And fortunately, I'm now able to answer the phone, and life has and God have provided me many more things than just being able to answer the phone. But I'd seen what it could do. I really maybe liked the process is not like the word to say, but I eventually did. And, I thought I'd really like to do that. And as I was kind of getting back on my feet and, taking care of myself in early recovery, I started thinking about that and looking at schools, and, then I started working a bit, and I kind of got in the same thing, once I make enough money and pay all this stuff back, and then I'll go to school. And fortunately, I had a mentor who, after talking to her a few times about this, just said, I'm just going to tell you, it's time for you to come work for me. I'll train you and you can go back to school. And that's what I did. And I started working at a place where we treated people for trauma and addiction, all types of addictions. Like, many of the people there didn't have substance use. They had other process addictions, or, really were there for primary mental health. And they stayed with us for 3 months to a year. And we were really working with very complex post-traumatic stress disorder, complex systems, like complex families, and doing a lot of very experiential and even, I would say, spiritual work with them. So I really it was inpatient.
Okay.
Yeah.
Okay.
And it was, I started kind of branching out and studying a lot of different, mindfulness practices, breath work. Before it was cool. I probably should have started an app back in 2010.
Made a
I
lot of
wrote a
money.
book about it. I was doing breath work and Yoga Nidra before it was cool. And it was there long before me too. And breath work's probably one of the oldest things that's been around, right? We've all been breathing since the dawn of time, I would imagine. Now everyone's like, oh, you got to breathe. I'm like, well, you've been breathing for a long time. Let's maybe bring some awareness to it. And, I worked there for a while, and, it just, I was really inspired by the transformation that I would see in people. And then we started running these workshops that were for the families of the people that were in treatment, or for people that didn't really qualify to be in treatment for a long time, but were kind of stuck in some area. Maybe they identified some trauma. Maybe they were just stuck. And so it was a the kind of sometimes where there's smoke, there's fire. They were left with all of what trauma can leave, fixed kind of negative emotions and fixed negative beliefs about themselves and the world, and being really stuck in a certain cycle, which would kind of point to a shaping from earlier in their life that they were having difficulty applying in their current environment. So, I was able to see then that I could work with, apply some of these techniques we were using to really acute patients in a residential setting to people who were functioning in the world. And then somebody came through who was writing a book, and he had a mastermind group of men and asked me to come design a weekend for them. And then, it was like these men from all over the world that were really, the lives were working, but they, were looking to develop further. And we would run these weekends that were very similar to what we would use for people that were experiencing, significant trauma, and really dive into their history and look at it. And, these guys were able to discover a lot of stuff about themselves. And many of them found that they were really good in transactional relationships and not so great in vulnerable relationships or emotional relationships. They knew the playing field of work or, high performance, because it was, there was clear rules. I'm sure your community, there's rules of engagement, even if it's not fun stuff, at least what to do. And that when they were in, their relationships with their spouses or girlfriends or children, relationships that are ambiguous and emotionally unpredictable, that they didn't know how to deal with it, even though they were really smart. So, that led me to doing more stuff with organizations, larger organizations, even like businesses, and leading some kind of from a leadership perspective, some of the stuff where we look at our history and know how we were relating to people. And that took me to working all over the world. I got to work in China doing it, and all over the US and in Europe. And I always kind of kept a foot in working with, mental health and a lot of addiction treatment. So after working there, I started consulting and helping programs build and training therapists and training teams. And, I've gotten an opportunity to work with many different populations, including, the soft community to a degree. I wouldn't say I'm an expert in it, but definitely have come across that quite a bit.
In your opinion, because it sounds like you've had a pretty robust career to this point, in the sense of getting to work with kind of a pretty far spectrum of clientele, getting to travel, getting to do consultation. I'm curious, what are some of the biggest differences, or just differences at large, that you've seen from working with just, the run of the mill individual that's wrecked their lives and they're coming into inpatient, to maybe C-suite execs, or, businesses where you're doing consultation and doing the same work? Like, what are the differences that you've seen?
That's a great question. And I actually have a presentation where I start off with this. I start off with, even when I'm giving it to people that don't identify as having trauma, I start talking about post-traumatic stress disorder. And I use the diagnosis to look at, how people respond and are left with things that are very acute and intense, whether they're event-based or, developmental or relationally based and happening consistently, right? Chronic, chronic, what people call like small T traumas, and when we look at that, if you look at the DSM-5, it says that, the person was exposed to actual or threatened, deaths, violence, some version of danger, right? In the DSM-4, it said real or perceived threat of death or annihilation. And, I really talk about, I go in and say that, whether I'm working with somebody who's in a very acute crisis in PTSD with the symptoms and the diagnosis, or often when I'm working with somebody who's super high performing, that's just trying to figure out how to take the next thing on or deepen their relationships, that there's this, it's like on a continuum. And the difference is the acuity intensity in which they experience the challenges in life, and how they deal with stress. And even as we see the people who are in these acute settings start to heal, they start to move up that continuum. I was, often I'll talk about, like, somebody who's high performing in the business world, whatever, an executive, founder, CEO, and they can handle anything at work. They can handle any crisis. They look at failure like it's just informing them on how to succeed, and then they get a text from their wife that says we need to talk later, and they fall apart. Like, and so that's not to like diminish anything that people who are experiencing something extremely intense and acute, not to take anything from them, but it's a very similar thing, right? That, I believe that our chief problem as human beings is that we confuse discomfort with threat and then respond to discomfort as if it's threat. Mm-hmm. That we go into survival mode of some sort when survival mode is not called for. Hmm. And, I saw this interesting, like, I can't remember if it was a comedian or something the other day it was like an Instagram reel or something where he was talking about like my ancestors responding to my current life. And he was like saying how I didn't get a great night's sleep. My cold plunge was shut down. Like, I'm feeling anxious about work. And then like it had his ancestors talking like from 6 generations ago and like the potato famine in Ireland. And they like didn't even have any of that stuff, and I'm not saying that it doesn't exist now, but we don't move around like we did before. We don't expend the energy like we did before. We don't have to, we don't have to hunt and gather, their primary, I really think like, I don't know how long ago, but it can't be more than 200 years ago. Like, what do you want to be when you grow up? Wasn't a question. Yeah. I'm not saying that that's a bad question to have now, but it was just like, you're going to be a farmer. Right. Your last name is Smith. You're going to, put shoes on horses. We didn't have a lot of these things to bump up against and create anxiety or like sitting in our heads and not moving around a lot. Not that that's the only solution. I'm not saying go back to that. There's a lot of things that our current environment has that, sure, it doesn't look like it, but we live in the like most peaceful, healthy time in human history, statistically speaking. I mean, people will challenge that, but we're just aware of it more than there's less conflict. Not saying that the conflict we have is great, but there's far less than ever before in history. And it's actually less violent, right? I mean, it's, and infant mortality rate is way down compared to what it used to be. They used to not even name babies in certain places for like a year because you were just sure 20 or 40% of them weren't going to make it, So I think that I kind of went off on a tangent here, but I think that we confuse discomfort with threat. We've got a lot more things that we perceive as threatening now and we're probably living at less threat than we ever did. Like probably the most dangerous thing you and I will do today is get in our car and drive somewhere. And most people aren't afraid of that. You don't think, well, could you imagine if we brought someone from like, 1800 and even put them in like a 1982 Toyota Tercel, it'd freak out. Right. And so, I think it doesn't mean we go back to how we used to be or anything like that. It's just understanding that, we don't have the struggle that we used to have, and struggle isn't necessarily a bad thing. And so when we're left without the physical and kind of struggle that builds that type of grit, we end up kind of living in these, imaginary or, fantasy states of like what bad is going to happen next, and looking for threat.
I want to talk about,
I don't know if that answers your question about what the differences are. Yeah. I mean, there's obviously differences of, there's people with more significant, more ingrained mental health disorders and things like that when you add addiction. But I think everybody, when I look at like even addiction, and we can talk more about this, and addiction isn't really a clinical term, but I think it's an important term to use because that's what people use and relate to. That I think we all fall in. I usually have this cycle, like say trauma, stress, and addiction, right? Trauma, expand the definition of that to being kind of a wounding, what shaped us. We all have it. Like having wounds and having a wonderful life are not mutually exclusive. In fact, they're mutually inclusive. Things break, people die, we experience tough things throughout life, right? So, some people more than others, right? Or more acute, but we all do. It's not, have I experienced trauma? It's what is it? And not to then use that I think there's been some challenges with that, and as it's become more of a word. I mean, 20 years ago, people weren't talking about this nearly as much as they do now. And there's some benefit to that, but there's also kind of, it's maybe become too much, like it makes people weak. They're a victim of something. Even if they were a victim of something, it doesn't mean that they have to live in that state forever, right? That it actually, they don't have to walk around like a wounded bird for the rest of their lives. In
Right.
fact, it's something that can actually make them stronger and more resilient. So trauma, the wounds that we experience, and then the stress is that and post-traumatic stress disorder is a stress disorder, right? And that's pretty academic, right? I can say that, but it's not the trauma disorder, it's a stress disorder. What is stress? It's the relationship to the trauma. The example I was using is like when I was a kid, I broke my leg and it wasn't set properly, or I didn't get the right physical therapy, or they didn't treat it at all. It'll heal, but I might have a significant limp that could have been prevented. But now I have this limp, and I'm a 50-year-old man with this limp and that limp isn't the break, it's the relationship to that break. But that relationship, we'll call the stress, may inform for me how I walk or don't walk, how I run or don't run, how I participate or don't participate, how I view myself, how I view my place in the world, how I view others view me. I mean, it can have it. So the effect of trauma isn't really what happens. I'm not saying what happened can't be really bad for people, but what happened is over. It's what our relationship to that, and it's what happened internally inside of us because of that. And it leaves this imprint on our nervous system, right? I mean, I think you found me through this, but my friend Andrew Huberman, the neuroscientist and podcaster, he says like the fastest way to brain plasticity is a traumatic event. Like it can in an instant change our worldview, right? It doesn't have to for everybody, and we know it doesn't for everybody because people experience things so differently. Like some people even like deal with veterans coming in that everyone wants to talk about combat, which may be something that really they experience some significant injury in. But some of them, that's not what the case is. It's like, I still can't deal with my relationship with my mother when we reel it back, right? Like we start looking at their history, and they were taught to be special operators before they were special operators. In fact, maybe the job chose them versus them choosing the job, right? Like, I'm like, holy cow, they were a soldier before they were soldiers. Granted, the ones coming to me are the ones that are having challenges. So I'm not saying that's everybody,
Right.
but I'm like, holy cow, you were able to handle like crazy amounts of stress, and live with it and work through it. Okay, so it's no wonder you can be a success in what you're doing.
Yeah.
So there's the trauma, then there's the stress, is the relationship, so that broken leg, and then the addiction, which we expand that definition to be just any maladaptive behavior that causes some sort of injury to us over time. Like it's not helping us move forward. It could be a substance, it could be a drug, it could be food, it could be sex, it could be a bunch of other, it could be a behavior, it could be certain times I'm watching Netflix because I'm trying to check out versus I'm sick in bed. And so there's a nuance to it. But if we expand that definition of addictive type behaviors, then that's not the problem, that's the solution, right? That's what we're using to calm the stress. Now, that cycle, trauma, stress, addiction, when you get into addictive behaviors, it causes more trauma, it impacts your body in a certain way, which causes more stress. You add more stress to the system, so it becomes like this loop. But it's really important, I think, to understand, okay, people are coming to us a lot of times because they want to deal with the behavioral issue, the addiction, right? And we need to deal with that. But that's on the top of the ocean. That's the waves. Underneath the behaviors are their emotional state, right? And usually these kind of fixed negative emotions. And then underneath that are these beliefs, which are really kind of fixed negative beliefs. We talk about PTSD. People are stuck in these emotional states, and then stuck in these beliefs, these negative beliefs about themselves, the world, or their place in it. Like the world is dangerous, men are bad, women are evil. I'm bad. It's my fault, right? And if we look at behaviors at the top with emotions underneath that, and then the beliefs underneath that, they're almost always in alignment with each other. If someone's living in fear or shame, their behaviors will end up being fear-based or shame-based. We can make sense of almost any crazy behavior. If they're living in fear or shame, and we get underneath and see the beliefs that, like, it's all my fault, I'm evil, of course you're going to have shame-based emotions in
Right.
that. Right. And shame and fear and anger and guilt, those are all appropriate emotions. Like, if I do something wrong, it's good to feel guilty so I can go make it right.
Sure.
If I feel afraid, it's when we're walking around with what I'll call like existential shame, just about who I am. That speaks to something that was maybe thrust on us before. So, so we want to, in healing, it's a top down and bottom up approach, right? It's looking at, we need to intervene on the behaviors, whether they're coming to us or going to a treatment center, right? They're just talking about it. They're working with the group. You need to intervene on it some way. And then build the capacity to experience the challenging emotions. Like, don't run from fear. How am I able to experience it?
Right.
I always say my website what I don't put on my website is how to feel bad is what we really do. Like, building emotional resilience and capacity so that then we can understand the beliefs and then challenge them and then start to kind of reorient and build if I'm oriented toward, if my orientation in the world is everybody's out to get me, I'm going to, that's what I'm going to see coming.
Right.
I think Einstein said the most important decision, oh man, now I'm going to forget it. You're going to have to cut this piece out.
You're good.
Is I forget. We'll remember what it is, but it was something about like is this a cruel or forgiving world? Something like that. We'll need to put it in the chat or something,
Yeah.
but like,
you're good.
what's the decision that I'm making? And if it's a fixed belief, like, if I have fixed that, like, people are out to get me, I don't want to go the other way and say nobody's out to get me, everybody's on my side,
Right.
because that's just not the case. But we want to get to what the community you represent does a really good job of in their training, which is getting to a neutral state where we can use discernment really quickly to decide, is that a bad guy, like those old in the TV shows where the cardboard cutout would come out, or the video game,
Oh,
is that
yeah.
a bad guy with the gun or a grandma with a baby? Like, if you already decide it's a bad guy with the gun, you're going to kill the grandma with the baby.
Right.
If you decide it's a grandma with a baby, you're probably going to get shot by the bad guy with the gun, right? It's like, how do we instantaneously, make that decision, right? And I think that falls through in the rest of the world. So, we want to be able to get to where our history can be an asset that informs us rather than a liability that drives us.
Yeah.
I apologize. I just said a whole bunch of stuff.
No, you're good. And I'm going to circle back. No, I couldn't agree more. I teach as well. So I was talking to my students yesterday, and pounding in their heads, like, all good therapy is built on exposure therapy. And at the end of the day, you hit the nail on the head. We want to make people more resilient in the areas where, for whatever reason, life has pushed them down, or experiences have caused some of those wounds, and they've not responded well, and they've figured out maladaptive ways of dealing with it. But the other piece that I want to circle back to, and you've hit on it a couple of times, but I want to ask you, because I hear this discussion among clinicians and academics in this space, but I've also have a similar background to you in walking through some of this personally, and have seen this. Why do you think some clients or individuals, when they walk through this, they have this self-identification of, like, I'm an addict, as opposed to, right, what we see in the DSM? And I hammer this with a lot of people with post-traumatic stress that get in their head, like, I'm a habit lifelong. It's like, no, it's a spectrum. You could have 4 criteria for major depressive disorder, and you're not fully diagnosable until you have the 5th, but you could have the 5th for a short amount of time, do therapy, and then come off, and you're no longer labeled as that. But it seems like, specifically in the SUDS community, that for some people, there's something about being able to label themselves. And I don't know if that comes from the professionals on our side, or something they latch onto. I'm just curious if you've ever thought about that. And
Yeah, I have. And sometimes I might get a lot of people that push back on this, but I don't ever think it's, words do have weight. But just like with clients, like, if you say, well, label them special operators, right? Yeah, of course, there's going to be some criteria or some common thread that they all have, yet they're all individuals, right? Someone who's got depression, right? They've got a diagnosis, and if we're looking at them as the diagnosis, first off, it could be way off. That's a whole other topic we could get on. Most psychiatric diagnoses are done in like less than 15 minutes. They're based on what hopefully a trained professional is seeing, but it's still through their lens. It's based on the history of the person, and people giving their history were terrible historians. Someone who's depressed right now has a terrible history. They might think, some of them would think, well, last year life was perfect, or I've always been depressed, when maybe 6 weeks ago, if you asked their spouse, they were like they were performing much better. They just have a clouded vision of it, right? And so, not that that's all wrong, but to be able to understand and really know what's going on with them holistically, right? That a diagnosis is something that helps us know the direction to go with people, but we shouldn't trust it implicitly all the time, right? It could be something that was given in a point in time that might be different. So I think when it comes to, if people label themselves an alcoholic or an addict, I think we also should take and understand where they're coming from with that, right? Everybody, just like if I ask a room full of people what the definition of trauma is, if they're all therapists, it might kind of hit in the same place, but I'm still going to have a bunch of definitions, right? If there are people that aren't trained, I'm going to get a bunch more, and some of them are going to be way off.
Yeah.
I think it's important to understand how are the people relating to that. I'll use myself. I'm in recovery. I don't talk about how I do it, but I do it, and I'll say I'm an alcoholic. To me, and this might be not true for anybody else, but for me, that means I found a solution. I've got opportunity. I've got possibility. I've got a spiritual connection with my creator. It means a lot to me, more than what someone that might say, because sometimes people say, well, you say that, why are you keeping yourself down? It actually lifts me up, because I've got that definition. Again, that might be and I know a lot of people that do.
Right.
There are other people that say, I'm a recovered alcoholic. And then there'll be people that debate, are they in recovery? Are they recovered? I think it's a waste of time if we look at that on, we got enough problems in just treating this to say, you're saying it the wrong way, and I think there is, from a policy standpoint, from a way that we talk about it, from as professionals, there's some real importance for us to look at that. Like, we don't label the people, that we see them as individuals and let them come up with it, whatever it is. So I think there is I'm not saying it's not important. I don't want, because, if people go, oh, they're just addicts, like that's not helpful either. Right. But, so I think there is a responsibility that we have in order to, change some of the stigma. But I think people also identifying as an alcoholic or a drug addict has helped them change the stigma, because we've heard people identify. In fact, there's a movie, I forget which one it is. I don't know if it's Anonymous People or another one. It was a documentary about drug addiction. It had a lot to do with 12-step communities and stuff like that. They were talking in there, and I might get this perfect, but it was like in the 80s, when the AIDS epidemic came out, and HIV, and it was like, there's a very different societal relationship to HIV today than, I don't know how old you are, but I remember, and I'm pretty sure it was a Time magazine, but it was like a picture of like a mosquito on somebody's skin. Like, we didn't know, we thought we were going to get it everywhere. I remember there was a kid in Florida, I grew up in Florida, who had HIV, got it through a blood transfusion, and it was like this big thing whether you could go to school. Like, I mean, it was wild. And a lot of people were dying. There wasn't a cure for it. There wasn't, now people can manage it and live sometimes healthier lives than people that don't have it, if they're managing their medications. It's a pill or two a day, or sometimes, I don't know what it is now, but I don't know that they cure it. I'm not a medical, but people live with it.
Right.
They get married with it. They have families. It's not what it was. And, there was like a point in time when like the Magic Johnson stuff came out. There was like there was like this shift because
Yeah,
everybody was dying.
that was a big
Anybody that
shift.
got it was dying, right? And so in this documentary, they kind of related it to that alcoholism and drug addiction hadn't had that. When people realized, especially in the communities that were most affected, in the gay community and in the it was the addiction community also, right? That they started to speak. I think they called it "Speak Out or Die" or something like that, and there were like marches and everybody was like speaking out about it. It wasn't hidden, and because people started speaking about it, they saw the people that were being affected that also had families that you didn't think, it wasn't just these people in some corner that nobody knew dying.
Right.
And within X amount of years, there was like treatment. People were living, and they were saying they're like addiction really hasn't had that. I think maybe
Mm.
in the past couple of years, I mean, we're seeing it a little bit different way. You see all these people on Instagram, which is great. I'm sober, live a sober life. We just finished. Well, I guess tomorrow we finished whatever a lot of people do, dry January. So the bars are going to be full on Sunday, right? But it's all pent up.
Yeah.
Buy Budweiser stock today, right? I'm not related to. I don't have a fiduciary relationship with Budweiser, but so I don't know if that answers your question. I think it's important for us to see them as the people as individuals,
Yeah.
and understand what definition they're bringing to it, and is it helpful for them?
Yeah.
And what does it mean?
Yeah. No, I agree. I think at the end of the day, it's important for the individual, the client, that if they've found some sort of strength in self-identifying, or at least even labeling, hey, this is the struggle and this is the word I use or the name I use, I think that's beneficial. I was just curious because like I mentioned, so many people sometimes throw around the term addicts or whatever, and at the end of the day, as you know, the diagnosis is more of a spectrum, but neither here nor there.
Yeah, no, and listen, I think even when you look at and I'll speak about this from more of an academic perspective, but I do think everybody that treats addiction in any way should read the A literature, whether you agree with some of the stuff in there and then the way they talk about higher power or not. There is no denying. I mean, a lot of it was informed by Jungian psychology very directly, but also it has impacted a lot of, indirectly, I think modern day psychology,
Hmm.
modern day personal development. There's a lot of it's it's a little bit old. They just came out with a plain language one that doesn't have some of the kind of writing from the 30s, if you can get past that. But even in there, they label the type of drinker.
Hmm.
It's not a clinical manual. It was written by clinical people. It was written by people who were getting sober together and recovering together. And they talk about the teetotaler who doesn't drink at all, the social drinker who can take it or leave it. They talk about the heavy drinker, right, who has the consequences of alcoholism or alcoholic, right? They drive drunk, they ruin relationships, but they get a DUI, but they get one. If their wife says, "I'm going to leave you if you don't stop drinking," they stop drinking,
Hmm.
right? If their boss says you're going to get fired, if they get arrested, that's the last time, right? They, under the right circumstances and consequences, they'll stop, right? And there's actually a lot of recent studies. I can't quote them, and we can look them up, but I think there's a huge, significant percentage. I think the majority of people who identify with having a drug or alcohol problem at some point in their life stop on their own, just eventually.
Hmm.
And when you look, our country actually has a huge number, like a huge percentage of our population. You wouldn't know it by the bars and the advertisements on TV and stuff, but that don't drink at all or can very much take it or leave it. Now, we also have a significant population who doesn't, but so they talk about the teetotaler, the social drinker, the heavy drinker, and then they talk about the real alcoholic in there, right? Which would be like looking in the use disorders in those three after the teetotaler. Maybe you meet one criteria, then maybe you meet four, then maybe you meet eight, right? And in the face of consequences, in the face of harm, in the face of a lot of pain, they keep going, right? So I think even in so it's important to say it's not binary. It's not like I just have it or I don't,
Mm.
and especially when we look at specific drugs. I remember treating a lot of younger men in my early career. That was when it was the oxy, now there's fentanyl, but it was when Oxycontin was, just crushing everybody, this is crazy because now, like, I remember when it was like 50,000 people died due to prescription drug overdoses, which they called poisonings, right?
Hmm.
It surpassed car accidents. We called it an opioid epidemic. And last year it was like well over 100,000, right? It's not seen in the same urgency, I think, as it was. I think, although with fentanyl, it's coming back to that, which is good. But these kids, 19 years old, like, it was easier for them to get OxyContin than it was to get a Budweiser.
Yeah, I
The
mean,
drug
it
dealer,
was in their bathroom medicine cabinet, you know?
bathroom medicine cabinet, drug dealers didn't ask for IDs. They weren't. I mean, listen, that I don't know if you remember, but there was that commercial that used to say, "This is your brain. This is your brain on drugs," and it was like a frying pan, and like you crack the egg and put it in there. It's a frying egg. It would say, "This is your brain on drugs." That's like the worst description of drugs ever, because that's not what it feels like.
No,
It feels amazing. Like, it's
it
not
feels
like
really, really good.
people
That's why they
people are
do
like,
it.
my life, and a lot of times it's not like my life is terrible. It's like, oh, everybody's doing this. It's amazing.
Right,
Like, they call things like ecstasy because that's what it feels like. And I'm not promoting that.
right.
It's that like, you know, it after some time you're gonna look like that. But you tell a kid that, and then all of a sudden, they did it and they felt great and like they fit in, they're gonna be like, oh, those guys are lying.
Right.
Right. So um but these kids, like, it was hard to say, you need to, and treatment a lot then, and still to a degree, but it was like really abstinence based. And I think that can be really great for people. I mean, a lot of the studies are showing, right, that some people used to say some alcohol is good for you, but I think it's more and more proving that none is better than some.
Right.
But if you're going to do some, I mean, there's a lot of things we choose to do that none would, I ate a cookie yesterday. No cookies would be better. Or we had s'mores last Sunday night around a fire at our house. Like, eating marshmallows none is probably better than some, but my family had a great experience doing it, so we'll choose to do that. Now,
Right.
I didn't eat 1,000 of them and go into diabetic coma afterwards, so I don't think that's a problem. But these young guys, like, it was like I couldn't label them and say you have this. They had a use disorder for that period of time. A lot of them stopped. And I still wouldn't recommend that they would start drinking right away, because it lowers your inhibitions, and then they're in college, and then it's easier to take the drugs and go back to them just because you're not thinking clearly. So, I think there were a lot of people that I hate to say grow out of it, but they were at a point in time.
Yeah.
That doesn't mean that they're not at higher risk now going forward, right? They do become that. But I think it is important to look at how we're labeling them and how we're treating them. And, that I think that's where some of the use disorder helps. I think some of the use disorder also helps because it can help us ease people into it. There's a
Mm.
lot of people that I'll see that I'll be like, holy cow, they really need to stop,
Yeah.
but they haven't, you can see where it's going, and it's not going anywhere.
Yeah.
It doesn't get better on its own. Right.
Right.
And but they're not in enough suffering. And you can just see this person, like, they might live another 20 years doing this. And at that point, it's like
Yeah.
everything becomes a mess. So it is helpful, I think, to be able to see how people are stepping into that progression. But
No,
diagnoses aren't perfect either.
no, and they're changing. I mean, there's, I'm looking at the DSMs right there. You got the DSM-5, you got the DSM-5 TR. As you mentioned, the 4 has different language in the 5. They're talking about bringing out a couple new diagnoses in the 6, and so yeah, it's something that's going to continue to change. I think the relationship from trauma to substance use, and ultimately it being a form of treatment, I think is really important for people to understand, especially family members, loved ones, spouses. At the end of the day, people aren't doing something just to make themselves feel worse. In fact, it's probably the complete opposite.
It is. They do it for good reasons. Now, then it takes over, right?
Sure.
I mean, it takes over, and I don't listen. I don't think people do have choice and accountability and stuff. But some of this stuff is so powerful. I mean, walk through the airport. How many people are looking at the person next to them and talking?
Yeah.
Everybody's looking at their phone, right? So do they have choice not to look at their phone? Absolutely. But it's so powerful.
Yeah. Yeah. They got a chemical reinforcement not to.
And it's so powerful. And it doesn't, if you put it down, you're not going to go into some withdrawal that's going to make you feel like you're going to die.
Right.
You know, some people might have some negative experiences doing that, but I mean, you know, people with opioids and like kratom, which was like legal, which is crazy and change. I mean, some of that is the hardest stuff to detox off of.
Yeah.
You know, I mean, a lot of people don't realize that alcohol and benzodiazepines, you know, Valium, Xanax, things like that, those are probably, and I'm not a medical doctor, but those are probably the most dangerous to detox off of because you can actually die. You can have seizure and die. Most people don't, you're not going to die from cocaine withdrawal or opioid withdrawal. You're going to wish you were dead with opioid sometimes. And people could dehydrate and it can be dangerous, but it's just like, and so uncomfortable. And, you know, cocaine and other methamphetamines are just very I mean, it's a psychological withdrawal that's extremely powerful, right? But from a medical perspective, alcohol and benzodiazepines work very similarly they're almost like, again, I'm not a doctor, but they're almost like alcohol in pill form, right? So they operate in a very similar way in the body. Are very, very dangerous, you know, to just go cold turkey.
Yeah.
If you've reached a certain level of
threshold of use.
Yeah.
And chemically your body's kind of switched over to
but I mean,
quote unquote needing it.
Yeah. And so, yeah, that's where like going back to what you said is so right on. Like people do these things for good reasons. They're not like, doesn't mean they're doing the right thing for good reasons, but and then it takes on a life of, you know, a kind of a life of its own and becomes very, I mean, it's addictive. And, you know, we are still kind of in the infancies of understanding all of this. I mean, there's stories from the heroin treatment centers in New York in the 80s or late 70s where they didn't really understand cross addiction, you know, like alcohol. They would tell them to go to bars and drink because they thought if they were being social, they wouldn't do heroin. You know, people said cocaine wasn't addictive for a long time.
Yeah. Long time.
That person has never been around somebody that is using a lot of cocaine and doesn't have any left. Like, so, you know, and the DSM's changing, right? I mean, the DSM is helpful to us to a degree, but we shouldn't take it as fixed. It's changed. Right. You know, I mean, how many diagnoses were in the DSM-4? Significantly less than the DSM-3. I mean, there's no such thing as Asperger's in the DSM-5. I mean, DSM-4 to the 5. Those people didn't get cured. They just got shifted over to autism spectrum disorder, right?
Yep.
PTSD was an anxiety disorder. Now it's its own.
Yep.
In the third version of the DSM, homosexuality was seen as a personality disorder. You could not be a psychiatrist if you were openly gay.
Yeah, I tell my students that
you were a mental defective.
Yeah. Yeah.
So it changes based on medical science. It changes based on social acceptance. It's a moving target, and that's important to know. And these diagnoses follow people too, right? They got diagnosed by this person, and then it's kind of stuck with them. And unfortunately, which this is a whole other podcast, in the world of managed care, you know, you have to diagnose right away, or they're not going to get paid.
Right. Yeah. Yeah, that is a whole nother conversation. Good Lord, we could talk on that for a long time. How broken that is and how backward that is. Something you mentioned earlier, you were, and I'm going to butcher it, but you were alluding to, you know, some of the first responders, military and soft guys that you've worked with. At the end of the day, you've recognized working with them, geez, it was almost like, you know, you were prepared for this before it even found you.
Yeah.
I was interviewing Jeremy Noble. He used to be a assessment and selection psych for the 75th Ranger Regiment. I asked him that question. I was like, "Hey, are you guys?" I'm butchering my own question, but basically, are you guys, you know, screening? And at some point, is that childhood trauma? Is that a no-go? In fact, it's quite the opposite, which I get to a certain extent. And his response was on par of like, hey, if I've got a captain that's, gone through the academy but never had any significant trauma, but he's all squared away, like that's great. But then if I've got this enlisted individual and I can clearly see that, he's had this pretty significant trauma, but then he's able to take care of things and he's really calm under pressure. He's like, what's this? I'm paraphrasing, what's more reliable at that point? The one that's got built-in resilience or one that we have an unknown
Yeah, I
factor
mean,
on.
I had a friend of mine that was in the teams, and I don't know that this is true other than what he told me, but he said in a lot of the SEAL trainings, the first people that kind of got out were like kind of elite athletes, because they trained under like perfect conditions. They knew how to, someone can correct me if this is wrong, but they were training under, it was the people that just had that grit, that they could push through anything. And I think any training in the military is less, it's not, there's skills training, but to me, it's all about a nervous system training. Like I was not in the military, but someone could take me out. They lived by the beach. They could take us out to the beach and over time could teach me to be a great marksman, right? They could teach me how to shoot the weapon. They could teach me how to clean it. I could become very proficient in it. That wouldn't make me a good soldier because the minute someone shot at me, I'd shit my pants, drop the gun and run away. Like how do they orient to turn into danger? Like same thing with firefighters, things. They run into a burning building. That's flipping the nervous system like upside down. So, and then I know with the soft community, the trainings are even, it's more about like, how much can you do without sleep and hallucinating and under these extreme conditions. Of course they need the skills, but that's not what's
right. In your experience, whether it's military related, soft related or not, the individuals that have, I'll just say, more significant trauma and they've figured out a way to utilize it so that they're at least successful. Maybe they're burning down their life personally, but they're a surgeon or, a C-suite exec and they're doing great. But it's crumbling. Let's just say it's headed towards not working. Do you see those individuals having an easier time to course correct because they found a way to make it kind of work initially? Or are those people the type of individuals in treatment that you've seen that no, they almost need to bury the nose of the plane into the ground before they kind of course correct?
I don't know that it's hard for me to say one way or the other on that. I think it's based on the individual, because a lot of them haven't found that way kind of found them. A lot of them don't realize that their work, that they have this solution that they push through, that they're able to handle stressful environments in the workplace and they don't necessarily, it wasn't like they sat down and go, this is what I'm going to do. That's just how they operated,
right.
That said, it can be because of some of those people, depending on what they experience, have a lot more. And sometimes you can challenge those people a little more. Like, look, dude, like you can't. I'll tell you, a couple years ago, I'd had a really stressful day, and I picked up my daughter from school. She was 5 at the time, and she'd been at school late. She had a cookie. I think it was Valentine's Day. They made cookies, and I had the cookies in the front. We were going home. We were going to eat dinner. My wife was making dinner for us. And she was sitting in the back seat, and I said, she said, Dad, can I have that cookie? And I said, I was like, she wasn't going to get the cookie right then, but I was like, really good parent. I was like, yes, but you can have it after dinner. So it wasn't a no, it was a yes.
Yeah, gold star, Dad.
Which I try to teach her. Once someone says yes, even if it's later, it's a yes, but they don't get that. They want it now. Yeah. Hell, when I want a cookie, I want it now. And she started whining like crazy. And it was just like, I was like, at the wit's end.
Yeah.
And I was like, I said, Lola, I just really sternly, I looked in the rearview mirror. I said, Lola, stop whining. I can't handle it today. And she stopped and she looked in the mirror and she looked at me and she goes, how can you not handle it? You're a daddy. And I was like, okay, good point. Do what you want. I'm like, I'm asking you if maybe you could keep it a little bit quieter, but you know what? She was basically telling me, I'm a kid, Dad. This is what I do. Right. She challenged me in that moment. Right. And not to say that's the exact same way, but I mean, sometimes it is like that with us. Be like, look what you're able to handle. How are you not able to do this? Right. They're like, I can't handle this. I can't. Of course you can.
Yeah.
Right. Sometimes it makes it easier in that way to challenge them. But then sometimes those people have also been challenged so much that you need to go the other way and be more like soft
Carrot
and
versus the
open,
stick.
right? So it's how are they listening? How are they oriented? You know, how long have they been doing this? How ingrained is it? You know, what other things are involved if it's substances and things like that. So it's hard to it's hard to say. Um, but I think, of course, it can be used as a benefit, you know. And also, like, I will say, for some of those folks, I think once they get through that, the recovery process can be easier because we're not asking them to than somebody who's just not been able to function at all, because we're not asking them to throw everything away. Like, we're not asking you to, like, a lot of everything you've done has helped you survive up until this moment. A lot of it is just applying those survival strategies appropriately at inappropriate times. Like, I'm going into this reaction when it's not called for. You know, and you know, there's a lot of people I work with, they'll be like, I don't want to get rid of this thing because I'm successful, I'm crushing it at work. And when they're able to kind of slow down, become more authentic in who they are, meaning they show up as the same person throughout their life. Of course, they might wear a different uniform, or metaphorically or actually at work, or speak a different language, you know, different vocabulary versus at home, but they're not compartmentalized. You know, when they're able to do that, we'll find that they're able to be more successful at work or be able to enjoy their success, you know, versus like, I have to do this because it's compensating for this other area that I've compartmentalized. I don't know if that answers your
How
question.
much actually ties into the soft community that I see that play out all the time. And my question to you is, in general, like, how much of that do you think is tied to their perception of their identity? And I will use the soft community as an example. Is like, you know, I'm whatever. I'm a guy in the teams, or I'm SF or whatever, and they've you know, wrapped their identity around who they are, but specifically what they do, and not really taken. And it's almost binary. Not taken a step back and realize, oh, I can do that here, but then when I go home, I can still be the best dad in the world, and we can be vulnerable, and I can talk to my daughter, and we can have tea parties. It can be both and.
Yeah, I mean, I think that's a really complicated challenge, right? Because both and in certain environments could be dangerous for them. You know, and I think that probably impacted a lot of people in the conflicts in the last 20 years, because they could get out of a conflict and call home and do a FaceTime. Like, my grandpa was in World War II, served 2 years. He never see his family until then, right? And then he was in a special forces, whatever the precursor to that was. Spent all his time behind enemy lines, and he had a lot of, you know, a lot of him. But, you know, he didn't talk to anybody. You know, they didn't have, like, I think then when Vietnam started, they would fly from Vietnam to Hawaii for leave. Like, how, like, that's got to be a intense experience. You know, because you don't want to shut that off in one environment, right? And we're not good in transition. And then like my grandfather, he rode on a boat for a month to get home, like, with other guys. Like, it has to be very, very, not to mention that, you know, people are surviving more with different woundings and stuff like that. But I think having some sort of transition, like, you know, I think the challenge becomes is like, they do such a good job in training of training the nervous system to orient toward danger, that a lot of times I've often felt like you know, the discharge needs to be a different nervous system retraining to orient toward, you know, things that you can't control. You know, like, I was not in the military at all, right? But I've worked with guys, and I can imagine some things, right? Like, I remember, you know, I'm 50. So when I was in my 20s when 9/11 happen. It was in my late 20s. And those like few days after it, as tragic as it was, like it felt to me, and I think a lot of other people I've talked to, it felt like really good to be, we felt united, like as an American, like, and I could imagine like a kid that's like in a, experiencing that feeling, and now they're, coming from a traumatic or dysfunctional family, and they're like, man, I want some of that. And then they join, right? And then and even if it wasn't, that's the way they came to it, they come from another way. Like what a purpose-driven life you have. Like people are literally willing to die for you. There's a mission and purpose and brotherhood. And like, it's whatever you agree with, don't agree with politically, anything like that. Like what a amazing feeling that has to be. I've experienced it on like sports teams and stuff like that, but it's nowhere near that.
Right.
And then you're left with going home and like, someone's complaining about the air conditioning at a Starbucks or something, right? When you're worried about or your kids are, they're not responding in the same way, or like, it's not like life or death. Not that life or death has to be it, but like, it's got to be a very confusing, disorienting experience, which makes me wonder, how much of it, maybe not, there might not be an answer for this, but some of those challenges, especially in the special forces communities, is it PTSD and moral injury, or is it like I'm so disoriented that I don't have purpose and team and all of this anymore? Like, who am I? Is it an existential crisis? I'm not saying that makes it any better or worse, but sometimes the focus goes on the thing that we think it's going to be.
Right.
This is not military, but I remember I was working with these clients. It was a workshop, and this guy was in there, and he had this like very intense 9/11 experience. He was in one of the buildings. He got out barely. He helped some people out. He was not a guy that would normally in life be seen as like a hero. Like he was like a financial guy, not like the one that's like out making the deals either.
Right.
Like the
crunching numbers.
Not that there's anything wrong with that, but he was not like he was more of a introverted kind of, but he had this crazy story, right? And then he also had this upbringing with like a narcissistic mother and stuff like that. And everybody, when they would give him, the clients, the other therapists even, they would just start going to 9/11. And like, I think I asked him some question or something when he finally was like, yeah, like, I almost hate to say it, but that day, like, doesn't bother me like it does other people. Like, I actually felt like a hero. Like, I got some, it wasn't like a good day. I mean, he wasn't saying that. Yeah. He's like, I can't deal with the stuff left over from my mom. So it's easy, I think, for clinicians even to get distracted by the shiny, big, and not that there wasn't stuff.
Sure.
I'm giving a very, that's a very short. So I want to be sensitive to that, but I think that's to say like every soldier has PTSD. I mean, is it Sebastian Unger's book Tribe? I think it was, where he talked about like the majority of diagnosed PTSD was from people that weren't even on the front lines.
I don't know if he said that, but I actually just got done doing some writing, and I'm gonna butcher who said it, but and it was actually a journal article. There was a larger percent, I would say, that. And again, I'm trying to cite the actual journal article because I just read it in the last month, but there was,
regardless, even if it was the same amount or a little bit less, like that speaks to, okay, what did they come in with? Like, and what, when they left, what did they lose? More so than it's just this, not that moral injury isn't is not a intense, very important topic to look at. Not that, what people are left with after that, but, so much of it is, you read Man's Search for Meaning, Viktor Frankl's book. It's like,
it's one of my favorite.
The people that lived had some sort of purpose. Like almost losing some sort of purpose is almost greater than any sort of like suffering people could be put through.
100%.
Or maybe I should restate that. Having that purpose can propel people through almost any type of suffering. For those who haven't read it, he was a psychiatrist, or I think he was a psychiatrist.
Mm-hmm.
He was in the camps in the Holocaust, and they could kind of tell in his, I don't know why I snapped my fingers, but they could tell almost right away when they saw one of their people in the camps that was going to die, because they saw that they'd kind of given up on any hope of. And it wasn't like they had purpose in there, but they had something outside of there that was pulling them them through.
No, it's one of my favorite books, and I'll add one of the paraphrases. Frankl talks about at one point, one of the prisoners, I think that because he was at a couple different camps, including Auschwitz, he noted one of the fellow prisoners had a dream that the war was going to be over on March 28th. They're going to be liberated. And for like 2 weeks, he was just telling everybody, and he was like full of hope and like excited. And the day came and the day passed. And because it didn't happen, and he was so set that it was going to happen, he was dead in less than a week. And so, no, to your point, I couldn't agree more. I personally think, and this is something me and another colleague are working on, I think when you look at the military and then you add in the soft community, I don't think you could create professional sports, and they're very similar in a lot of ways, but very different in a lot of ways as well. But when you take what's happening psychosocially, Erickson's work, late teens, and you introduce them into this community, and it has purpose, it has uniforms, it has order, it has a sense of community, right? All these things that are really important to us. And then you take them through some meaningful suffering and some meaningful loss, and you build this career, this individual, and then in a drop of a hat, sometimes they're med boarded and it's very, very quickly. Sometimes they're very aware of that transition coming, but that purpose being gone that once was so ingrained, and that community, I think that's one of the hardest pieces that I keep hearing from individuals from this community and the military, and even first responders. It's the loss of that purpose that is so damaging sometimes.
You're literally on the hero's journey, like in the way you just described it, right? And then you're out of it.
Yeah.
And just I think it is productive to talk about professional sports. I mean, it's not the same in some ways, and in some ways there's a different intensity to it, because in working with professional athletes, if they made it, if a guy made it to the NFL, he is the smallest percentile of people that play football that make it there,
Mm-hmm.
right? And the last guy on the squad and the best guy on the squad, their talent is not that far off from each other. And if they were that good enough to make it in the pros, then how good were they in college, where the pool's bigger?
Mm-hmm.
And if they were that good in college, how good were they in high school? And if they were that good in high school, how good were they in Pee Wee football? These guys have been heroes. They've since they were 8. Some of them having their families, expect them to, which is crazy, because I think it was Jonathan Haidt or somebody else that was talking about, like, no, maybe it was another guy. It was talking about like something like 20% of, it was another guy, 20% of parents of kids in like sports as kids think their kid is going to be a professional athlete. And it's like 1% of 1% that, and like a lot of those, like, professional sports they're not going to be, Tom Brady or something like that. Right. So, but in working with some of these guys, they're very good at what they do. And then they get out by injury, or they're 35 and it's done, and they have they had stuff done for them their whole lives. It's stuff done for them their whole lives. They don't know how to do anything, not because they're not capable, not because they just don't know how to do it.
Yeah.
They don't know how to like shop for something sometimes, definitely don't know how to handle their money. Like, but like, and then they're left with this social anxiety and like sometimes just have no skills for anything else, because this is all they did.
Yeah.
Again, not because they couldn't, but because like, they have been focused on one thing, and then they're lost and disoriented and like walking around like a shell of a human being.
Yeah. Yeah, I would love.
It's not everybody,
No,
obviously.
no,
It's not
no,
everybody.
no. When I talked to Jim Lynch, he was on the podcast, and I mentioned it to you earlier. His time at the Special Mission Unit at Bragg, and then working with Team USA Swimming and getting to work around Michael. He made that connection. He, noted he wasn't the first one to note that Soft and professional athletes were so similar. I would love someday, just as a pet project, to work with both individuals or groups, or even have a group of professional athletes in Soft, because I just think that there's so much similarity in some of the presenting problems and also the lifestyle. Obviously, some vast differences, but I think that there's a lot that they could learn from each other, even in a process group. I just think that there's, I don't know, my mind goes, I'm the idea fairy. There's a lot of things rolling around, but seeing what they present with, and to your point, the 0.001% in some of the different journeys psychologically that they go through. Yeah. So.
Yeah, this is long before I was a therapist, but I was young, I was 23 or so. I was working for my dad's building company, and we built a house for a four-star general who just retired from the army, and he was, I think he had one leg. He was like the most decorated soldier since, like, whenever, with him only one leg. He was four-star, commanded a bunch of troops, and he had retired. And I remember there was a lot of things about him that really stood out to me because I wasn't in the military, but we would go out to lunch and his wife was there. And first off, separate, but I'd always had this view of these guys as like just hard nosed, like I'm sure he was going to be a jerk. And this was like one of the most compassionate guys I ever met. Like he was like, one of the things he had said he missed the most was like being with the young men and like, how much he cared for them. And you could tell. But his wife would make fun of him because he didn't know how to do anything. Like she's like, he doesn't know. I had to teach him how to take his dry cleaning. He didn't know how to order food. Like he was the guy that, pull on base and like everybody stopped. Like everything was done for him
Right.
for whatever, however long. And obviously he was a very capable, smart man. But like she's like, he's like a child when it comes to like, because he's like, and of course he was learning and everything. It was very interesting, and that might be very different for people who's neither, but not that everybody's like, but there are a lot of things that are kind of handled, and that they don't have to worry about. And so then you get back in the world, and now you're used to dealing with really intense problems, and you can do it, like life or death things. And then things come across like a kid screaming about a cupcake or a cookie, and it's like, why are they acting like it's life or death, and then have no patience for it, right?
Yeah.
Or again, that's not everybody, but
Yeah.
it could be. It's very, like, especially coming in and out of being overseas and then coming home, like you're there so quickly, it's got to be so disorienting.
Yeah.
And I think that's a lot of what, just with anybody, a lot of healing and recovery is about reorienting, that we're disoriented. We've been, kind of using this certain thing for our magnetic north for a while. And now that's changed. And, part of the healing process, I think, is just being disoriented for a bit, and then figuring out, what's the direction I'm going to follow.
Speaking of the healing process, so we've kind of tore apart a few things. I'd like to push into, from your perspective, what's the process of change? Obviously, really good assessment to your point. Like there may be, bad previous diagnoses that sometimes our clients come in with. But from what you've seen on a 30,000 foot view, but also, I mean, maybe some case studies or examples, like what is specifically with some of the clients you've worked with, what is the tools that you like to use, and what does that process typically entail?
Well, I think number one is assessment and triage, right? So, if they're using a substance or something that alters their mood, it can alter their mind, and some sort of significant mind or mood altering substance or alcohol, like you've got to intervene on that and triage what's going to kill them or harm them the quickest, right? Because we also can't get a good picture of what's going on. The idea, like, of course, we're going to do an assessment when that happens, but I mean, in working with people in detoxes for a long time, sometimes you get the person, they're like, oh yeah, they're you know, they're totally normal. They're going to be great when they come in there, and then they come in and they get off the substances for 3 days, and all of a sudden they're like tearing down the walls and window because they're in some sort of psychosis, right? There was something else present that they were using, was being kind of medicated or pushed down by the substance. There are other people, they come in, they're like looking like they're the craziest person you've ever seen in psychosis, right? All this kind of stuff. And they come off of it, and 3 days later, they're acting like the most normal person you've ever seen, right? So we've got to, and there's some debate around this because some of the new ASAM criteria, like the fourth edition, is really talking about like psych evals right away. And I just, it's not super beneficial to eval and diagnose when someone's in an acute withdrawal from substance or alcohol. I mean, if you're going to do it, it needs to be redone. But I think triage, right, and assessment, getting to a full assessment, which is not just psychosocial, I think biopsychosocial, spiritual. So, who we've got to look at them medically. I mean, the new, the old criteria in the DSM-4, where we were really looking at the axes, criteria, kind of carved medical out, and we're supposed to be in the DSM-5 looking at medical first, right? So they're presenting with symptoms of depression, but we find out that their blood sugar, their insulin is, or their blood sugar's 400, right? Uncontrolled diabetes is going to have symptoms of depression, right? Or other things going on, right? So that can impact sleep, sleep apnea, heart problems, things like that. So not all these things are going to happen, one at a time. Some of them are going to overlap, but, looking at a full panel on them and understanding what's going on with their hormones, men and women, stage of life type of things, the different sexes are going to have different, things going on medically, potentially, depending on stage of life. So I think really getting a baseline on what's going on with them like that, I think, if there's going to be medication, and I'm not the one diagnosing it, but medication from my perspective, when I'm working with somebody that it doesn't, so many times we get people that are, they're shooting heroin in their neck, and now they're like, I'm not going to take medication. I'm like, what are you talking about? Like, but because a certain medication is prescribed or could be called for, doesn't mean you need to be on it forever, right? I think, in fact, probably for the lion's share of people, antidepressants were developed to really be like, use them until the symptoms lessen, and then a little bit longer, and then taper off of them. Now, that's not been what they've used for. Most antidepressants are prescribed by primary care providers without psychological or psychiatric evaluation. I think a lot of people are prescribed some of these things when they're sad because of life experiences and not really clinically depressed. So we're not really, and this is where the diagnoses and the DSM can be really helpful, because we can see, not only do you need these symptoms, but you need these symptoms at this level of acuity for this period of time. I think anybody could have almost any symptom in the DSM at any point in their life, but if you don't have it for X period of time, you don't have the diagnoses, right? Like, I could, I got sick a couple weeks ago, and I woke up extremely, what I would describe as anxious. I was sick. I couldn't get some stuff done. I felt like I was behind. It wasn't a generalized anxiety disorder. My nervous system was just tapped,
Right.
and I had stressors going on. And 3 days later, it was a different story, So, had I gone in and like described what was going on and exactly what it is, if I didn't have someone who was skilled, they might have said, yep, you've got generalized anxiety disorder with the depressive features, and you need to be on this medication, and they just give it to you and don't look at it again. That's not everybody. There's some very good docs and very good psychiatrists out there. I think it's a matter of working with an interdisciplinary team and figuring out, like, what is it that we're going to use, especially a lot of psychiatry, a lot of medications can be used interventionally. How are we going to use these right now? Like you talked about the stellate ganglion block shot. I think that's not going to that's not a miracle cure for people,
Mhm.
although they might feel like a miraculous relief, but it's enough to take the edge off so that you can get in there for things like therapy or like if someone's in that state and they really need physical exercise, they need to eat right, they need to do these things. Like when you're in that kind of state where you're at hyper, it's very hard to do that. It's almost impossible.
Yeah.
I'm feeling like I'm going to die, but I'm going to go to the gym. Now, some people are able to go to the gym because that's the only thing that regulates it. But like, so, looking at them, what it, their physical state, and then a psychiatric and social thing, like what's happening with them in the environment that they're in, what about their family system, their relationship with their work and their identity. So that's the assessment part, but I think then in treating it, right, you treat it kind of in that same order too, especially when it's substance use. A lot of people don't come in as internal, we would like for people to be internally motivated for change. Most people aren't in general, aren't internally motivated they'll say they want to change. Like I did this post a few days before the New Year's, like the two busiest times I am as a therapist getting phone calls are like right before New Year's and about like February 15th. So it's people wanting to change going in, and then I get a bunch of calls from people who made all these resolutions that they haven't met, right?
Yeah.
So, pain is a great motivator for change, but Thoreau said most men lead lives of quiet desperation, right? If you don't turn if it's not like status quo is a pretty safe and comfortable place to be for a lot of people. So even when it comes to significant problems, people tend to get internally motivated for change just till they get back to the status quo. That's not everybody.
Yeah.
So we need to support them in, helping them there's like a window of grace that opens when they're in a lot of pain and they see things clearly, or they see a path clearly, or they're willing to do some things. Like we got to help them keep that open. So looking at some of the things that they're impacted medically, things that are impacted socially, are there legal troubles, are there relational troubles, are there financial troubles, psychiatrically, and helping them kind of use those things as some external motivation, to while they can build some of that internal motivation. And, if we look at treatment in the ASAM criteria, even coming from like a medical detox down to intensive outpatient, it's like a medical container, right? We're going to treat you medically with some psychological or therapeutic services.
Mm-hmm.
Then residential treatment would be more of a wraparound interdisciplinary team around psychiatric, psychological, and therapeutic services and peer services with medical, right? And then you step down into PHP, which is like 5 hours a day. Maybe you're living in a sober living or something like that. They're starting to get some freedoms back, right? That's more clinical with less medical. And then you're getting down to where, I'm seeing an outpatient therapist once a week or twice a month, and I see my doctor every 6 months, right? So we got to treat things medically, from a medical perspective and psychiatric perspective first, and then you're kind of stepping down into, as people get more physically stable, right? In those beginning stages, it's hard to challenge them emotionally. You don't want to bring up their deepest trauma,
Right.
but we start, as I was saying before, intervene on the behaviors, build the capacity for emotional or distress tolerance, build distress tolerance and emotional resilience, so you can, which you talked about, get into more of the exposure therapies. And exposure therapy could just simply be revisiting the memory of it. It doesn't have to be actually going to it. And
Right.
that needs to be done in a nuanced way too, because you just don't want to throw somebody into,
The deep end.
the deep end, right? You want to pendulate through activation and resource to help them move kind of closer to the whatever their fire is, so that they can eventually kind of sit in it and see that it's not necessarily a fire, it's just really uncomfortable, and then move through it. But I think in the continuum of treatment, that's where we're moving toward, and as people get more emotionally stable, we can start, and physically stable and emotionally stable, start looking at, what are the things that we can challenge behaviorally, psychologically. And I think really good therapy challenges people. I as a therapist, I believe people pay me to help them challenge their thinking and innovate and invent new ways of thinking and behaving, not yelling and screaming at them,
Mhm.
but, as a therapist, and when I supervise or train other therapists, I say, if you're not wrong, sometimes you're not doing your job.
Mm,
Like, they're paying you to take a risk. You're a human being that they're trusting. You hear things, reflect it back to them. You might be completely wrong,
right.
but you might be completely right. It might be the timing. It might be the way you're communicating, but
Um,
it's important to do that. So I think I don't know if that explains the
yeah, yeah, yeah.
the healing
No,
process, but
I'd love to get into a little bit deeper of some of the things you mentioned, the breath work and some of the other interventions, or at least I'd love to hear a little bit more about some of the interventions that you guys typically rely on. I did just want to reiterate, I can't tell you, you know this, I know this, but the clients sometimes, especially in the military, are conditioned to just, hey, if somebody's got a white coat, like they know what they're doing. And again, there's great medical doctors, but I can't tell you how many times I've met clients that have just said, I went to my doctor and just told him I had anxiety and like, this is what I got. And I've been on this script for 6 years or whatever. And it's really easy to be misled and, or for doctors to just go along with what clients are presenting. And so being an active role as a patient in any primary care setting, especially in the military. And I know there's a conditioning of just, well, this is what I'm being told to do, so this is what I got to do. I think is extremely crucial. And then to your point about, kind of who walks into therapy, we talk about this pretty regularly. There's generally three people that walk into therapy that I'm always assessing for. There's the customer that, if I tell them to go, proverbially jump off a bridge or cut off their arm for homework, like they're in so much pain, they'll do it. Like they're motivated. There's the complainant, the kid that gets, drug in by mom or dad because he's smoking too much weed, or, the husband or the wife that's, cheating or just doesn't want to be there. And then there's the visitor that's just kind of, yeah, I'm here, I'm doing this. But when you push them to change, there's no real movement. And they can definitely change even in therapy. But I think you highlighting on those two things are extremely important, because the set and the setting, both externally, but also internally in the individual, I think is critical, especially when you get into substance use treatment, because there's so many variables that could be at play that could offset, the trajectory of
and
treatment.
and you're right. I mean, I've worked with so many great doctors and psychiatrists, and like the ones that I have made such a meaningful difference, for me, for the teams that they're on, and for the clients, are the ones that know they're only seeing them for a little bit, right? And then from my perspective as a therapist, I'm seeing them for a little bit more, or my team is, and it's the peers or the behavioral techs that are taking care of them that are probably know them better than any of us.
Yeah.
And when you can pull that whole team together to really see somebody, that's the beauty of residential treatment, right? You start seeing, because people show up at the doctor, they might be more guarded, it's shorter, right? A certain way. Then they show up in therapy, they're either on their best behavior, like everything's fine, or
Right.
on their worst behavior, they're malingering, and it's like, oh, my life is falling apart. And then they're like playing games with, people, and laughing and joking out in the, and not that they're lying, that all is telling.
Yeah.
But when we can kind of understand, that's a way in which we can kind of understand people holistically, and really support them. As far as some of the modalities and things, I love things like, like I've had a lot of great success personally, and with treating others with a form of breath work that's more of a therapeutic form. It's kind of in line with Stanislav Gross teaching of breath work.
Can you flesh that out
Um,
just for our audience?
yeah, so like a holotropic type breath work. So listen, breath work's gotten I was joking earlier that I should have started an app in 2010. Like, people say breath work, there's so many different forms, right? So there's like, and there's, first off, we're breathing all the time, right? So it's a matter of us kind of bringing awareness to it, because we don't breathe fully. We don't, and when we can, one of my teachers always, Amrit Desai, used to say, if you want to change your, the breath is the mind made visible, he would say.
Hmm.
And then if you want to change your mind, first change your breath, right? And so first off, there are forms of breath that are going to upregulate us, give us energy and focus, right? That's more leaning into the sympathetic nervous system. There's breath that's going to downregulate us, kind of activate the parasympathetic nervous system, which is more the rest and digest and could help with focus, right? But might be the difference between like a sniper and someone who's kicking indoors, right? Of how they're breathing and acting, right? It's both might be focused, but in different ways. One bringing energy, one kind of helping them stay like in an almost dorsal vagal. Snipers are an interesting one to me because I've often seen them as like at their most hypervigilant state. They're like the most calm for the longest period of time. Like hypervigilant, like super hypervigilant and aware, but their heart rate's 40.
Right.
It's like a very dorsal vagal response while being super alert, which can have some impact later on. That might be a longer topic, but so upregulate, downregulate, things to help you be calm, all kinds of little tools like that. I think one thing that's important is as we want to build emotional tolerance, vagal tone, which like helps us expand the vagus nerve, which allows us to be in discomfort. We want to we want to relax more, right? But relaxation is active. It's not passive, right? So if people are in a sympathetically charged state, so they're activated, fight or flight, right? The solution for that is not to deactivate the sympathetic nervous system. Try telling someone who's pissed off at you to just relax. See how well it goes. I don't know if you're married or not, but it doesn't work when someone tells me. It doesn't work when nobody. That just doesn't work. What you want to do, not deactivate the sympathetic. It's an activation of the parasympathetic. Okay, so how do we do that? One of the fastest ways is through breath. I believe if we're in sympathetic charge, we have a breath pattern, right? We're breathing a certain way to bring in oxygen to our body, and there's something in that signaled to us we're at threat, perceived, actual, threatened, real or perceived, right? If in that moment we can change our breath to breathing with very slow inhales and very slow exhales, I think that sends another signal to our brain and nervous system that says, hey, if I can breathe like this, I'm probably not actually at threat. Again, some military for applications might be different than that, right? Or even first responders or police, but generally speaking. So, one of the things we tell people often when they're like freaking out about something, we say, take a deep breath. Well, if you go like that, that's actually activating more of the sympathetic nervous system. Kind of our inhale is more of a sympathetic activation. Exhaling is more parasympathetic. So of course, to take a long exhale, you have to inhale deeply, but you can do a slow inhale and then a very long, slow exhale. And if people try that, you can feel your system start to kind of downregulate.
Are you having people do this in session or group session when they start to get activated, or practices outside a session? I'm curious.
Both.
Okay. Yeah.
Both. I mean, sometimes you don't want to just always change activation because the idea is not to get out of activation. Right. It's to be able to kind of be with it.
Yeah. Stay in that window of tolerance.
It depends on where they are. So you don't want to throw them over the edge either. But I was just talking to another group before I met you. I've been talking for like 5 hours straight today. So, my wife is going to be happy about that because maybe I won't talk so much tonight. I actually think one of the byproducts or one of the side benefits to smoking, and this is not an argument for smoking or vaping, but if you watch, most people don't breathe fully. Like if you watch a kid or a baby breathe, their gut comes way out. And most people that we've been kind of conditioned to hold ourselves a certain way, we're just not doing it. If you watch people smoke, if you went to a yoga class or meditation, say, take a deep breath, hold it at the top, and gently let it go. If you watch people smoke, what do? Yeah. Hold it at the top, gently let it go. And so I'm not saying start smoking.
Brought to you by Marlboro.
No. How about this? Take breathing breaks like people take smoke breaks.
Oh, I like that.
These are like, I'm a big fan of like micro meditations or micro breaths. Like it's very hard when you're activated to say, I'm going to meditate for 5 minutes. No, just like I'm going to take 7 breaths. You're going to breathe anyway. I'm just going to change it and see. It might just take the edge off enough that you're not, So there's different forms of breath work like that, and people define it in different ways. There's like Wim Hof breath work that helps build capacity. There's different things. The kind that I'm talking about that's like in the holotropic or rebirthing, or I call it conscious connected breath work. It's more akin for many people. I might get attacked for saying it like this, but it's more akin to like what I think a psychedelic experience is like. When people are in this, it's not really a controlled, other than they're controlling the breath. And a lot of people will experience or re-experience either traumas, pains, emotions. Some people have a very visual experience, like in a dream. Some people have a very kind of emotional experience. People will get really tense and tight and then kind of release it. They'll have a very physical experience. And like psychedelics, again, people might argue with me on this. There's not necessarily like an immediate long-term structural change that's going to like, I'm done forever. But I think what it does is it creates a touchstone experience. I think PTSD, we call it a stress disorder. And I said that earlier, but it's really like a state disorder, or kind of stuck in a certain state. And if people can experience a different state, they might not stay in it, but now they know that it's available to them.
Right.
So I've had so many people in these experiences be like, "Wow, I've felt forgiveness. I felt inspired. I felt free. I felt peace." Now, I don't know that they're going to feel that the next day necessarily, but even just knowing that that's available increases the chance of that happening the next day.
Right.
So it's kind of like there's a building that has an awesome garden on the top of it, like a skyscraper, and you didn't see there's no staircase or elevator. And now you've been rocketed up and you can like see it and you can experience it. You might even be able to feel it, but you can't go up and down. So now we know it's there. It's available to us. We need to go build the staircase and the elevator so that like, I think a recovery, a healing process is more about recognizing when we're I'll just use the word peace, out of peace or off the beam sooner, and returning to it quicker, right? It's about balance in life. Isn't about standing still. Balance is like almost falling over, right? And then finding center. And then you take on something new in life and then you take, and find center.
Yeah.
So I love, breath work. EMDR is a great tool for people. Again, these things don't, people like, does it work? There's evidence-based, like with EMDR is an evidence-based treatment for PTSD and trauma. That means it's been studied a lot. That means there's been a lot of efficacy shown. Doesn't mean that everybody's going to have, there are people that have contraindications. They might have contraindications just at this point in their life, and you need to do some other work to get to it. Like if they dissociate a lot, there's also a practitioner involved. So there can be transference or countertransference going on that they don't respond to things in the same way. I really look at these modalities though, as there's, very simply put, there might be 1,000 modalities. And for me, that means it worked for one therapist and one client at least, right? And somebody was willing to pay for the training. They're doorways in. And some of them might be more effective and proven, and might be more effective with different people, and might have a long, but I feel like they're all doorways into the same room. And that room is the person that's in front of us. And so that we can get to understand them, we can help them get to understand themselves. Because when people know themselves and they know what their character liabilities are and their assets are, what some people might say are their defects and their virtues, they can start to understand like, oh, I'm feeling this way. I understand under stress. This is why I feel this way. That doesn't make it go away, but they can stop being shocked by their reactions to things. And like, why am I here again? They can understand it. And then they can start building strategies and tools to move through it, rather than just being like, this is so uncomfortable, I got to get out of it.
Yeah. I love that. I wish we had a little bit more time. Ryan, I want to ask, just because I know you got to jump off here in a second, is there anything that you wanted to hit on that we didn't hit on, or plug anything before we wrap up?
No, I think we touched on a lot. I hope it's helpful for some people. You know, I always say I am not the expert. You know, I might have expertise in certain areas. I've had certain training and experiences, and I love being able to have conversations like this. And also when I do other trainings, even with people that aren't, you know, I was just doing it with a group of business owners, you know, that we can, um, you know, and I always tell this to my clients, like, I might be seen as an expert in this thing, but I'm not an expert in you.
Yeah.
And I wish, you know, everybody would kind of understand that, you know, that my job, our job as clinicians is not to, you know, we're just guides, and really more like we're walking next to them or a little bit, maybe even behind them. And as a mentor of mine used to say, you know, our job is to listen to theirs very carefully, as their spirit will whisper to us what they need, you know, and to be willing to be wrong as a therapist, you know, be willing to be, you know, challenge each other on teams, and allow your client, you know, the clients to, I always tell my clients, you know, push back.
Yeah.
I might have this wrong. Like, don't just take this as the truth.
No, I think that's really important. And I really appreciate you pointing out, like, these are all doors. One of the things that I'm, whenever I do have a conversation with different people and they ask about the different modalities, I talk about it as a combination. Like, look, each client's different. Their story's unique. Their traumas are unique. And at the end of the day, it's generally a combination. Maybe there's psychedelics with EMDR and something else for this client, but for another client, it may be completely different. And to your point about, hey, these are all doors or tools in the tool belt to work with different clients. I think that's really important for, you know, us as professionals to recognize. It's not a one size fits all. Yes,
Yeah.
we have our kind of niche areas or our favorite modalities that we like to pull out, but at the end of the day, if we're not working with the client, allowing them to have pushback and change and an opinion in the room, like, we're not doing it right.
Yeah. I will say, you know, I have, if anybody wants to find me, my website's ryansuave.com. I've got a free course on there that it's really around emotional resilience. It's an email course that comes out. And then my YouTube channel is RJ Suave. I've just putting out videos every week. Just they're free. If you like it, subscribe. I've got some Yoga Nidra meditations on there, and I talk about different topics. You know, just kind of a mission to kind of help people and put out information there and get people thinking. So if you go there and subscribe, it helps me. I don't sell anything on there, but it would help for people to listen. So
yeah, we'll make sure to put it in the show notes. Ryan, I really appreciate your time.
thank you.
We'll have to get together again sometime. Thanks for watching. Please like, comment, and subscribe wherever you're watching or listening. And please share this content with your networks.